want to talk about the first presentation. Okay, I'm going to talk about the first presentation, and when I talk about the first presentation, it is when the head is fully extended so that the occiput is in contact with its spine. This is what we mean. But in first presentation, there is full extension, and this occiput comes in touch of the spine. And if it comes in touch with the spine, the baby will present with the face onto the pelvic brim. This is what it means by full extension leading to a face presentation. The incidence is around 1 in around 500 births, so it is not very common. But the types of face presentation, we have two. One, primary. This is when the face presents even before labor begins. And then we can have a secondary face presentation when the face presents when labor has started. And this may come in due to occipital-posterior positions, and sometimes even the brow, which is a partial deflection, can have a full extension, and then we get a face presentation. So what may be the causes? We said primary, this is when the face presents even before labor begins. And we are saying some of the causes is anencephaly, increased tone of the neck, which may be caused by spasms of the spine and tumors in the neck. This can lead to a face presentation. Or the secondary can come in as a contracted pelvis. Example is a platyploid pelvis. We have the head entering the pelvis into the transverse diameter, and the parietal eminences may be held up in the obstetrical conjugate. And as labor progresses, the head will extend, and the face presentation may result. Force of uterine contractions can also cause a extension of the head, leading to face presentation. Occipital posterior position may also lead to face presentation. And here we say that the head is caught up in the sacrocotyloid diameter, and the head does not descend, but it becomes extended as labor progresses. And this full extension will lead to face presentation. Then polyhydramnios, that is a spontaneous rupture, and that gush may lead to the head to extend. A pendulous abdomen, when the fetal back leans forward and the force of contractions are directed to the chin, this may result into extension of the head, leading to face presentation. Also, hypertonic uterine contractions may lead the head to fully extend. So when we take off face presentation, our denominator will be the chin, and we shall have the four positions: the right mental anterior, the right mental posterior, left mental anterior, and left mental posterior. So how are we going to diagnose face presentation? They are saying it is very rare to diagnose it because majority of the face presentation are secondary. They come in during labor. So in the beginning, it may not be face presentation, but as labor progresses, face presentation sets in. That is why it may be hard to diagnose. So during labor, on inspection, nothing is diagnostic. If we look at the abdomen, there is no clear sign that we shall suspect a face presentation. When we go palpation, usually it's also not easy to palpate because the lower uterine segment is tender due to overstretching. and if possible, the following may be seen. A presenting part may feel high, the occiput may be felt centrally, and there may be a deep groove between the head and the back. It can easily be mistaken to be a sinciput. This is what they mean, that in first presentation, if the baby is facing like this, as you palpate, you may come across this groove, and this groove, it can be mistaken to be a sinciput. It can also be mistaken to be a full bladder, so it is not easily diagnostic. The impulse of the fetal heart may be felt by the hand if the abdominal and maternal walls are thin. Here we are looking at mothers with thin abdominal muscles. The limbs may be palpated on one side or opposite to the occiput. All these may not be very clear during abdominal palpation examination. And when we come to auscultate, in case of mental anterior, the fetal heart is readily auscultated because of the nearness of the chest of the fetus to the maternal abdominal wall. This is what we are saying, that if the mentum is anterior, it means it is facing on the anterior part. It means as we put the fetoscope near here, we shall be able to listen to the fetal heart. But if the occiput, the mentum, is posterior, it is really very hard to auscultate for the fetal heart. Mentrolateral, the maternal heart is hard on the same side as on the limbs, and in mental posterior position, the fetal heart is difficult to hear because the fetal chest is in contact with the maternal spine. And on vaginal examination, the presenting part will feel high, and when the os is fully dilated, we shall palpate for a soft mass, and it may be confused by the anus. And the following may help us reach the diagnosis. The mouth of the fetus may be open, and when you go into the mouth of this baby, the baby will suck the examining finger. Therefore, we can think of the first presentation. When we continue to palpate, we can palpate the molar bone. We can also palpate the ridge of the nose, and also the orbital ridges may be hard. This is on vaginal examination, and these are few distinct results which may help us detect a first presentation.